Hi everyone! Thank you so much for joining us for today's coffee chat. My name is Bamboo Dong, and I'm a Scientific Affairs Liaison at Menarini Silicon Biosystems. Today we'll be talking about how to use and optimize user-defined markers to harness the full power of the CellSearch system for rare cell enumeration. Later on in the talk, we'll be talking specifically about using the open channel to look at HER2 expression in circulating tumor cells, but to start, we'll look at the best way to integrate user-defined markers into your research. As a reminder, the information being presented today is for research use only. For more information on CellSearch for clinical applications, please check out cellsearchctc.com. For those who are just hearing about us for the first time, we're Menarini Silicon Biosystems. We offer an integrated workflow for the enrichment, enumeration, isolation, and recovery of rare cells, including single-cell isolation and prep for downstream analysis. The CellSearch system is the first and only FDA-cleared technology for the enumeration of circulating tumor cells, or CTCs, in metastatic breast, prostate, and colorectal cancer. It's been used in over 650 peer-reviewed publications and has been extensively validated in oncology clinical research. It uses our proprietary blood collection tubes that can stabilize cells for up to 96 hours at room temperature and has 4 fluorescent detection channels, which we'll be diving into a little more today. So first and foremost, what are circulating tumor cells, or CTCs? These are cells that are shed by primary cancer sites or metastatic lesions and circulate through the bloodstream. They're readily detected from blood draws and can be an independent predictor of overall and progression-free survival. CTCs can also be a valuable tool to monitor disease progression, oftentimes reflecting changes earlier than imaging alone. Used together with traditional testing and imaging methods, CTC enumeration can be an integral part of the patient monitoring process. Because it just requires a tube of blood, it can be integrated into the patient's routine blood work and allow for easier serial testing. In clinical settings, the CellSearch CTC test predicts patient survival independently of other testing methods in metastatic breast, prostate, and colorectal cancer. Studies have shown that patients with fewer than the cutoff numbers of CTCs have longer overall survival, as well as progression-free survival. Serial monitoring with CTCs using the CellSearch system can also help physicians make more informed patient care decisions and can be an early indication of treatment efficacy. Patients whose CTCs remain below a cutoff or drop below that number over the course of treatment have a more favorable prognosis than those whose CTCs are above the cutoff or rise above the cutoff over the course of treatment. Here's an overview on how the CellSearch system works. Blood is first collected into a proprietary cell-safe preservative tube, which allows CTCs to remain stable at room temperature for up to 96 hours. After sample prep and centrifugation, cells are loaded onto the CellTrax auto-prep system, which automatically prepares the sample. Target cells are enriched for using ferrofluid nanoparticles and then further stained for easy identification. Once ready, the enriched sample is transferred and further incubated in the MagNest cartridge holder, which uses a magnet to pull the cells onto a single plane where they can then be analyzed on the CellTrax analyzer. Currently, there are several product kits available for the CellSearch. You can check out our YouTube channel for previous coffee chats about the circulating endothelial and circulating melanoma cell kits, as well as our upcoming circulating multiple myeloma cell kit. Today we'll be focusing primarily on our circulating epithelial cell kits for CTC detection and enumeration, but all of our kits do have the option to use a user-defined marker in the open CellSearch channel, which is research use only. Both the epithelial CTC and CXC kits are used for the enumeration and characterization of circulating epithelial cells, with the primary difference being the fluorescent marker used for positive identification of the cells based on expected antigen density. Both come with our 96-hour cell-stabilizing cell-safe preservative tubes, the ferrofluid capture solution, and the necessary staining reagents. You'll notice that in both kits, there's an open channel that can be used for a user-defined marker. Let's Let's take a look at how to optimize those markers in a research use only setting. Here's a flowchart that describes the process. We'll make this talk available after the chat, so you can take another look later, or you can always reach out via email if you need help optimizing your marker. To start, decide which kit to use. In order to do that, you'll need to ask yourself, how abundant is my target antigen? If it's lower density, we recommend starting with the CXC kit. If it's higher density, start with the epithelial kit. If the density is unknown, we recommend beginning with the epithelial kit. Next up, you'll want to determine the proper controls using a known positive, high, and low antigen density cell line, like the thumbnail to the right, and a known negative cell line. To measure the background signal, process 3 different cell lines without the marker reagent using a specific exposure time. Your positive signal should be strong enough that there's no ambiguity in relation to the background signal. Once those steps are complete, you'll want to carefully titrate your antibody to determine the minimum concentration for both the high and low antigen density cell lines. Then, optimize your exposure time using the low antigen density cell line. You don't need to focus too much on the images here. They're just an example of outputs from the CellSearch cell browser as you optimize your exposure time. Let's look at some recent key publications that have used user-defined markers to study HER2 expression in metastatic breast cancer. As a quick refresher, HER2, or HER2-neu, which is also known by a few other names like ERBB2 and CD340, is typically expressed normally on cell surfaces. However, when it is overexpressed, it can lead to dysregulated, accelerated cell growth. It's also one of the major canonical markers of disease in breast cancer, along with estrogen and progesterone receptor expression. Typically, HER2 expression is assessed on tumors during the initial biopsy using immunohistochemistry or fluorescence in situ hybridization, or sometimes both. Cancers that are HER2 positive tend to be faster growing and more aggressive, although the introduction of monoclonal antibody therapies targeted towards HER2 positive cancers in the past several years has drastically improved the prognosis and outcome of patients. What recent studies have shown, though, is that in some cases, patients with metastatic breast cancer whose primary tumors are HER2 negative may sometimes have circulating tumor cells that are HER2 positive. And being able to measure this effectively could have an impact on treatment decisions for patients. So one question that we hope to answer with the CellSearch is, can we interrogate HER2 alongside valuable CTC enumeration data for metastatic breast cancer? And the answer is yes. Here's an image from the CellSearch using a HER2 marker for the 4th channel, which is shown in the column all the way to the right. As you can see, these are cells that are positively identified as circulating tumor cells that are also positive for HER2 expression. One of the papers I wanted to highlight is a study done at the Institut Jules Bordet in Belgium, looking at HER2 positive circulating tumor cells in breast cancer. To start, they analyzed several breast cancer cell lines with known HER2 status using both immunocytochemistry and FISH to assign intensity factors. In this case, intensity is a function of HER2 signal compared to the background. Using the intensities established by the known cell lines, they were able to assess the HER2 statuses of circulating tumor cells from breast cancer patients. The most important takeaway from this experiment is that HER2 positivity using this method did not correlate to the HER2 status of the primary tumor. So what does that imply in the context of patient monitoring? In a study published last year in the US, researchers looked at the prognostic value of HER2 status on CTCs in metastatic breast cancer patients with HER2 negative primary tumors using the CellSearch system. It's been previously reported that the discordance in HER2 status between CTCs and tumor tissues may be as high as 50%. And according to a mechanistic study published in Nature in 2016, patients may acquire HER2 positive CTCs that have more proliferative potential than HER2 negative CTCs. And in addition, HER2 positive and HER2 negative CTCs may spontaneously interconvert during treatment, which indicates a potential mechanism of drug resistance. In this paper, the researchers classified patients as either high-risk HER2, meaning that they had 2 or more HER2 positive CTCs, or low risk, meaning that they had only 1 or 0 HER2 positive CTCs. As you can see, the probability of progression-free survival is much lower in patients categorized in the high-risk HER2 group. Using the HER2 status of CTCs, they were able to identify patients who might be able to benefit from HER2-targeted therapies. They found that patients who were classified as high-risk HER2 at the initial appointment, but who became low risk over the course of treatment, had a significantly higher probability of progression-free survival. Here's a few other examples of other groups who have been using the CellSearch system and CTC kit to evaluate other markers as well. Shown here is a study using PD-L1 markers for cells from patients with advanced urothelial carcinoma. In this study, CTCs from patients with metastatic breast cancer were characterized using an M30 apoptosis marker and apoptosis regulator BCL2. Here too, you can see the importance of establishing cutoffs to determine what is considered positive. And here's a paper that looked at Vimentin expression as a marker for epithelial mesenchymal transition and Ki67 as a proliferation marker in CTCs from patients with advanced castration-resistant prostate cancer. That's just a few examples of the great and innovative work that's being done out there on CTCs, but as we can see, open channel staining allows for powerful biomarker analysis in parallel with the already valuable information one gets from CTC enumeration. For those interested in looking into a fourth marker in their CTC studies and are new to CellSearch, we do have global lab services offering a range of tests. Our CLIA lab in the US is located in Huntington Valley, Pennsylvania, just right outside of Philadelphia, and in Europe, we have a lab located in Bologna, Italy. Here's a brief list of just some of the testing services we have available, as well as a partial list of additional markers that are available upon inquiry. If this chat piqued your interest in adding user-defined markers to your CTC analysis, we are hosting a mini symposium on May 4th that we are calling May the Fourth Channel Be With You. It will feature more in-depth information, as well as some really great guest speakers, including some of the incredible researchers and physicians that are currently using the CellSearch fourth channel in their groundbreaking new studies. And with that, I will open the floor to questions. If for whatever reason I don't get a chance to answer your question, please feel free to reach out via email. Thank you so much.